Hey, great to see everyone here at the end of the day. Thank you so much. It's been a fantastic couple of days and we're super excited. You know, with the Western Alliance, it's been growing year on year. And I've seen some fantastic presentations. The quality just keeps improving every year. So really tough to follow you, Akushla, and Drew owes me big time. That's just cruel, really. But I'm really excited to be here to talk to you about an initiative, our Centre for Australian Research into Access. And it's a collaboration between Deakin Rural Health, which is one of the university departments of rural health throughout the nation, and Grampians Health. So it's built on our relationship. And we've been working with Deakin Rural Health since actually 2016. They put their money where their mouth was and they co-funded a position at Grampians Health, and that was mine back in 2017. And then in 2022, we formalised the agreement and we had a MOU signed between the two organisations. And in 24, Grampians Health also put its money where its mouth was and helped to co-fund the centre. And I'm going to go say CARA because it's a lot easier to say. So as the title says, you know, CARA is really about addressing access-related health, education, and safety disparities between rural and metropolitan Australians. So when we're talking about access, so today we're really going to be talking about spatial access. So we're talking about the availability of services, so both, you know, the types of services that are delivered and delivered to the people that need them, and their accessibility, so largely time and distance. And we know that where you live will impact how long you live and how well you live. So it's really important. And this is built off some work, a range of work that we've been doing, but one of the studies that we did that was funded by the Western Alliance, where we talked to over 114 consumers in the Grampians region and over 70 health professionals to understand what they considered to be the main health priorities for them. And there were 400 issues that they came up with, and the majority of them were related to access. So this work is in response to that. So I'm just going to, when we're talking about how people work out where to deliver services and where to fund, you know, workforce, they will apply a measure like CEFA. So hopefully most of you know what CEFA is. So the ABS, the Australian Bureau of Statistics, has 4 indexes for social and economic disadvantage. And then they apply them to different spatial units. And spatial units are just kind of boundaries, and they're different sizes and they have different purposes, and they kind of contain different things. So we're going to work through this. So one of these CEFA indexes is the ERSID, and what it's just showing you there is that it's got 10 deciles. The lowest, the number 1, which is the dark, the purple blue, people that live in that decile will likely have the lowest incomes, lowest level of qualifications, and working in low-skill occupations. And then when we're looking at spatial units, this is just one that shows an LGA, and I'm going to show you an example how the CEFA gets applied to these different spatial units. And it's actually more exciting than what you think, so bear with me, okay? So what we have here in Ballarat, and for those that you know, we have 2 houses. These are shown by those green hexagons. One is by the lake, Lake Wendouree, and another one is further west in Ballarat. So we're going to just So on this left side, if we're using one of the largest spatial units that the ABS uses, which is the LGA, so that's, you know, local government areas, you can see that whole boundary is that boundary for the LGA, so it's pretty big. That whole LGA has got the one colour, so it's at a CEFA level 6. So both of those houses fall into a CEFA level 6. All right, we go to the next area down, so you can see there's a few more different coloured shaped polygons in there. They're postal areas, so they might have a few postcodes in them, but they're generally your postal, you know, 3350 for Ballarat. So again, what we see is those 2 green hexagons, the 2 locations. Again, both fall into the same colour. They're both C for 6, so about mid-range. When we go to SA2, so that's statistical area 2, and that's kind of an area where communities engage both socially and economically. And again, we see the two locations both fall, strangely enough, into a higher CFA, into CFA 7. We go down to suburbs and localities, and so you can see a lot more coloured polygons representing every suburb. And what we start to see is a bit of differentiation. So what you see is the house by the lake falls into CFA level 9, and the house further west falls into CFA level 6. And for those that live in Ballarat or know Ballarat, we know that we're probably getting closer to the truth here. And then when you get down to statistical area 1, and that's the smallest unit that the ABS uses, we actually see that the house to the west is CFA level 1, and the house by the lake is CFA 10, at the highest, has the least disadvantage. So huge difference depending on what spatial unit you use. So that's pretty interesting, isn't it? And this kind of shows this just in the graph. So the far side is the biggest spatial unit. The next graph is the smallest spatial unit. And what you see is that they are exactly the same until you get to the smaller spatial units, the CFA. So we don't really, if we're using LGA, we don't really understand that population. We don't understand what their needs are. So it's really important to get down to the finest level that we can. So this just shows you why we have CARA. So you go from LGAs through down to SA1s, but we're doing even better in CARA. So we have every address in Australia, and we can map time and distance from all of those addresses to any service using road networks. So not as the crow flies, but using the road networks. So we've got nearly 16,000 addresses throughout Australia. So this is one of the maps that we've generated through CARA, and this just shows you a change in access to general practice between 2 years, 2015, 2022. So 2015 over here, 2023, 23. And then this third map just shows the change. So green is improved access to GPs between those 2 years, and the red is reduced GP access. So generally, you can see better access when you're by the coast, so the GPs are moving to the coast. But we have just got one kind of weird area in the top of Victoria where there was better access, and I know that Matthew Hadfield, our Chief Medical Officer, said that we had a GP practice open up there, so that improved. And that can make a big difference, one GP practice. Now, I was going to try and be clever and go to my to the website, but I don't think I will. So I'll just go to the next slide. So this is another one, another bit of work that we've done looking at travel time to GP practices in 2025. So on this map over here, my right, your left, you can see all so the distances are, red is really close, like less than 1.5 kilometres, and then you're getting further away, greater than 75 kilometres. Yep, just checking out this. So the red dots are where the GP practices are, and this is kind of the west of Victoria into the bottom part of South Australia, and it looks like there's a heap of GP practices, so it looks pretty well serviced in that region. But when we look on this map, this is actually the bulk billing GPs. So when you look particularly at the bottom of South Australia, instead of having all those GP practices, you've actually only got 2, and people having to travel. So if people need to use a bulk billing GP, their access is severely restricted. So okay, I might need to go to my... sorry, excuse me. Thank you. Thanks, David. So this is just the map that I was showing you before, so I'll just show you... Sorry. Can you hear me? Yeah. too many technological things here. So just to show you, this is our CARA website, and we actually have all the addresses in Australia that we can map to. That's the map that I showed you around the change. This is just showing that within our CARA platform, we can map to any health service that's in the National Health Service Directory. So the National Health Service Directory is a directory that's funded by the Commonwealth and the state and the territory governments, so it's got all of those services. So we can make a map for any of these. It just takes a little while. So that just shows you, and we can overlay this onto, we can overlay CIFA or whatever else that we want to overlay onto these, just to give you an idea of the depth of the data that we have behind the platform. So, might go back to the PowerPoint, David. Yep. All right, so just to show you some of the work that we've done through CARA so far, so at the policies translation level, hopefully some of you are familiar with modified Monash. It is a large kind of spatial unit. There's 7 categories of modified Monash from 1 to 7, with 1 being metropolitan and then 2 regional out to very remote. And a lot of funding is based on modified Monash categories. So it's helped to determine workforce, it's helped to determine financial incentives and rebates. There's a whole range of things that are decided by modified Monash. So they just have done a review on the modified Monash, and our CARA was commissioned to do a report. And surprisingly, our recommendation was that we need address-level intelligence to be able to develop these service-specific models, because we know that by using these great big spatial units, you're actually not identifying the need of those communities. And so from that report, that went into the Working for Better for Medicare review. And then this year in the federal budget, they've actually funded putting a significant amount of money into revamping the modified Monash. And hopefully they'll go to address level. So bringing it closer to home, and a lot of you hopefully have seen our fantastic bus that Ash is driving around and is parked outside the Good Shed. And so we're really excited about our mobile clinical trials van. And we've done some mapping, and I did just to acknowledge Ash if she's here. I stole her slides because I saw her talk this morning and it was so good, so I quickly integrated her slides into mine. So this is some of the work. So this work is mapping all of our clinical trials. I think it was like 1,400, a bit over 1,400 participants across the state. So you can see the reach that we have because they're running the clinical trials in Ballarat and where they're coming from. This is showing on a slightly different format because this is done on our Grampians Health server. So we do all of this work behind our firewall so that we protect all of our patient data. So it looks, and because we're a public health service, we don't have all the schmick stuff that we can do outside, like on the CARA website, but we'll be working towards that, so it looks slightly different. And our senior data scientist is employed by Grampians Health. So he works for CARA, but for us, and so that he's working behind the firewall, so all of the data's protected. So this is just showing kind of the distribution. These are phase 1 trial participants, and really interesting to see the travel times that they're having to experience to get to their trial. And in phase 1, it's pretty intensive, so they're having to come a lot. Average time 45 minutes, but some people having to come over, nearly 3 hours one way. So it's a massive burden for them to be able to participate. And this one is using the old CIFA, just as a reminder for you guys on my little lesson on the CIFA. And just to show, we're really happy that we have the participant, which are the blue dots, out into the yellow and the lighter colour areas, which just shows that we're reaching people in the lowest socioeconomic areas. So we're really proud of that work. And hats off to Ash Clark with all her work around this mobile clinical trials unit. And the work that we've done with mapping helps us inform where we need to take that van. So just another application for CARA has been in the southwest, and this was funded by Barwon Southwest Women's Health and Wellbeing. I think I've got that right. And you guys can get these slides so you can have a look at the links. We had some media around this. Sarah Wood, that might be in the crowd here up the back there, I see, drove this work. She's one of our... Well, she just submitted her PhD and she works for Deakin Rural Health. So really proud of this work, and it's had great impact already, and it's helping them drive their strategy and their planning. So just some of the next steps that we're going to do. We've signed an MOU with the ABS to help geo-enrich their data. Pretty excited about that. Obviously, Australian Bureau of Statistics are probably the biggest players with data, so we're going to be feeding into some of their projects that they're doing at the moment. We're also doing some work around developing a synthetic population, and that's going to help us with modelling demand and services. And actually, the next big thing that we want to do is around workforce, and this will really ring home for people who are from rural and regional areas. We've got issues around, we don't even know where our workforce are working, or who's working where, or where they're coming from. Even at a health service level, it's really hard for us to know that. And there's a couple of issues around why we don't know the workforce. It's because we're using two larger spatial units to analyse our workforce data. That the summaries that we get from the governments really aren't made for workforce planning. And some of the databases, so like APRA, which is the Australian Health Practitioners Regulation Agency, something like that, close. So it only updates once a year, so there's a huge time lag in that data. And also that workforce registers, they don't always capture all the information we need for workforce planning. So not to pick on APRA, but they don't include all the health professions, so like dietitians and other self-regulated professions. So our next bit of work that we're going to do in the Grampians region, which work well because we have the amalgamation and we can kind of bring the data together, we're going to be looking at roster and payroll data so that we can get near real-time mapping of workforce. So we're really, really excited about this one, and we're going to be putting in for our partnership grant for this as well. Different scheme, hopefully. And we did talk with the Secretary for the Department of Victoria a couple of weeks ago. Super excited about this work. And just, I'm here obviously presenting on behalf of a huge team. So really great to have had this relationship with Deakin Rural Health. They're so committed to doing the right thing and doing the thing, as we like to say at the Western Alliance. So thank you very much.
Thanks very much, Anna. That was fantastic, and congratulations on all that great work. Come over here where I can see you. We've got a couple of minutes for questions, so would anyone like to ask Anna a question? Once again, I might start, Anna, by, this seems to me a very helpful tool for health planning in general. Have you had any interest from either state or federal level health departments?
Well, so we just spoke with Jenny Adder from she's the Secretary for the Department of Health for Victoria. I'm yet to follow up on that, but she was pretty good. She had a lot of questions, particularly interested in looking at the CFA impacts, understanding that. So, hopefully that is going to be the next step, that we get some input from them and at least some input for some support for a partnership grant.
Yep. That would be great, yeah. Any other questions?
Hi, I was interested in the mapping against GP access. How confident are you that the information you get about GPs is actually about that the GPs are actually there, I suppose is what I'm saying, because there can be a clinic in a town, but they might only be there 1 day a week, or they might be really transient?
Yeah, that's a fantastic question. So we're really good at mapping to bricks and mortar, and that depends on how up to date that is as well. But we really want to know kind of about the squishy bits inside, don't we? We want to know the workforce and how often they're there, and that's part of the workforce project that we'll do. So we'll really understand, who's there, what their EFT is, what their skills are. So that's going to give us that more detailed information. Yeah, so great question. Portia.
Thanks, Anna. Those were really amazing graphs and really cool. I was wondering if you guys have thought about looking at telehealth use, and if you think that layering sort of geographical spread of telehealth could tell you more about access in terms of who's far away geographically and also not using telehealth or doesn't have access to it.
Yeah, absolutely. I mean, we can use it for anything. We can use it for telehealth. And one of the things we've thought about is even mapping the, what do you call them? The internet, so you get internet access. The towers, yeah. Sorry, long day. So that because, we often talk about having telehealth or these, even like having online resources, but we're doing some work at the moment out in Eindhoven, and they're saying, well, we can't access that because we don't have internet, or if we want to do telehealth, we have to go in into the local health service to access it. So, yeah, really important. So, yeah, we absolutely can. And understand, different options for providing services, but actually how feasible they are in real life.
I've been told we can't have any more questions. We need to get you out of here. Thank you very much, Anna. Fantastic talk, fantastic work.